And some of y'all went really extreme. All I need to pay is even a half page. Okay? Copy down the book. I don't care. It's just something I have to put in y'all's folder. So you keep it. And then also, I only take up 2 people's homework every week and make a copy and give it back to you. But you never know who it's going to be. It'll be sure. Alright. So I just give everybody credit for doing their homework. And then, anyhow, so I'm going to put that in real quick and then we'll go over it.
Nikki just said she emailed you her homework at 9:47.
Where's she at? She's sick. What about Jessica Farley?
I think she's got a few.
Yeah, she had a few.
Oh, that's right. She's sick. Okay. Alright, let's go over your homework. Everybody sign in, please. Get some more trees. No. Okay.
Have you gotten the copy of the homework that she made?
Not yet. We'll go over first and I'll take it. All right, go over your homework. Number 1, you should have Doppler shift. What's another word you can have? Frequency shift. Okay, either one. Number 2 would be a negative shift. Number 3 would be positive. 4 is above. 5 is below. 6 is false. 7, blue away, red torque. 8, velocity. 9 is 60 degrees. 10 is continuous wave. 11 is aliasing. 12, you can increase your scale, decrease your baseline, use a higher frequency, and there's one more. What is it?
Decrease transient frequency, use higher Doppler range, move baseline, decrease DRS.
I knew there was another one. Okay, so there we go. I just couldn't remember the last one. Number 13 is scale.
See, that's where I do get confused, because like, there's one place in the book that said it was linked to wall filter.
Yeah.
But it also says it's linked to scale. And I think I made that clear. PRF and scale are the same thing. So.
Yeah.
14 is the FFT. 15 is autocorrelation. 16 would be decreases. 17 is name some advantages. It does an
Aliasing, less angle dependency, improved noise filtering, and improved sensitivity.
There you go. I just have a page number wrote down my answer here. Alright, and then some disadvantages of it are?
Doesn't show direction, high persistence, and lack of aliasing.
Here we go. 19 is a mirror image artifact, and 20 is also, it's called a ghost artifact, hard to read. Now, I think every question on your quiz was on your homework. So, good, good, good. Alright, anybody have any questions about that? Today is Lisa and Kim's day, and I'll make a copy and give it back to y'all and just see it. Yeah, and just make up the time after.
Well, I'll add it in our
No. Just whatever, it don't matter to me. Just as long as there's time on there, I don't care.
We have to have a certain amount of, like, hours. 2 hours.
Now that the class is, what, 2 hours? I think. 2 hours, yeah. What's it, 4 hours? Okay, so, alright, I'll get these back to y'all momentarily. Alright, we got a lot to go over today. gonna touch a lot on anatomy of the arteries that y'all been scanning. And then hopefully I'll have time if y'all have any questions about your scan. Everybody be sure and get all the goodies up here. Alright, the first thing we're gonna talk about is some anatomy. And I gave y'all a handout of this. But some people are better for drawing, even though I can't draw. I don't need help. So if you look at this one, it says the aortic arch. This is where we're going to start at. Alright, so, does everyone know the flow through the heart? Like it comes in through the right atrium and goes through the tricuspid, so we're all good there. Alright, it leaves the left ventricle through the aortic valve, right? When it comes out, the aorta is coming up right here. This is called the ascending aorta, okay? And the first branches off the ascending are the right and the left coronary arteries, which is also on your little handout. Now, normal ultrasound techs do not scan coronary. That's only if you do echo. If you don't learn echo, you're never going to do those arteries. But as the ascending aorta comes up, I think y'all had to draw, maybe y'all had to make this in anatomy, I know I did. But anyhow, it starts to look like a candy cane and it starts to arch because it's starting to come down. This area right here is called the aortic arch, okay? And it has 3 main branches off of it. And you do need to know them, and you do need to know them in order. The very first branch, which I didn't draw right here, this is this one right here. It is called the innominate, which is it's on your handout, innominate. Or it has another word, which is brachiocephalic. So B-R-A-C-I-H-O, and then cephalic, C-E-T-H-A-L-I-C, brachiocephalic. So the very first branch off of the arch is called the innominate or the brachiocephalic. Right? It further divides into the right CCA, so the right common carotid, and then the right subclavian. So the innominate will divide into the right CCA and the right subclavian. Right? Then you'll move on to the second branch off of the arch, which is the left CCA. And the third branch is the left subclavian. So that's all 3 branches off of the aortic arch. First, innominate. Second, left CCA. Third, left subclavian. Alright, and the innominate is also called the brachiocephalic. And it further divides into the right CCA and the right subclavian. Now, as you come on down, as the aorta starts to dive down, it's called the descending aorta. Once it passes through the diaphragm, then it becomes the abdominal aorta. And y'all may have learned about the celiac and SMA, don't learn about those branches. So that's what they would come off, the abdominal aorta, but we're not going to go that far right now. So we need to know that when it comes out of the heart, it's called the ascending aorta. It has your right and left coronary artery. Then it has the arch. It has 3 branches, innominate, left CCA, left subclavian. As it starts to dive down to the descending aorta, once it passes to the diaphragm, then it's called the abdominal aorta. And there's actually a little part here called the thoracic aorta also. That's more about that. Descending and then abdominal. Alright. Innominate, also called brachiocephalic, divides into right CCA and right subclavian. You will start scanning the subclavians before long. Now, if you'll look either on this handout or this one, either one, you will see how the right and the left subclavian, they have a branch that comes off them called the vertebral. Y'all see that? So each subclavian has a branch that's called the vertebral. In about 2 or 3 weeks, we're going to start scanning vertebrals. So, anyways, the vertebrals come off the subclavian. You need to know that. Right, vertebrals branch off the subclavian. As they travel up the neck, they go in the back of the neck. They're called vertebrals because they lie close to the vertebrae, the spine. Right, so as they travel up the back of the neck, once they get right here to where your skull starts, I hate that word, but anyway, your head starts, they join to form the basilar. The skull. I never say anyhow, so the right and left subclavian have a branch called the vertebral, right and left. They will join right before they enter into the back of the head and form what's called the basilar. And you can see that on your handout, how they join together, and now they have formed a basilar. You can't really see it on this one because they don't show it, but on the big one, it does show them coming up and forming the basilar. Right? You don't have to know anything past that right now, but we will finish this before this class, before this is all over. Not today, but you know what I mean. All right, so there's your three branches. The subclavians have a branch called the vertebrals. They join in the back, right before they go to the back of the head to form the basilar. And this page has the word brachiocephalic, so it's got both of them listed for you. You know both of them. Never know which way I'm going to word it. All right. And then also, either on this handout's pretty good. It shows how the CCAs come up and form the internal. Doesn't really show the external though. But this one is not too bad. It shows how the man is laying down. You can see how the external feeds the face. So that's why you need to rotate your probe towards their face. But then the internal goes up to the ear. That's why I'll say rotate your probe in towards the face or out towards the ear, because that's how the anatomy lays in you, okay? Now showing that. Externals to the face, internals going up to feed the brain, so that's why it's going straight up. And then the very last handout is just another little diagram showing the arch, the branches. It's alright, it's not the best stuff. That's just some things for y'all to look at to start to learn the anatomy. Lay this back out. Alright, now we're going to get into the book, so we're on chapter 2. Can anyone guess, while we're looking at arteries, what might form in an artery to cause a blockage? Plaque. You said it, plaque. Now the word plaque has like 3 different words and they all mean the same. So if you hear someone say the word atherosclerosis, and I think I gave it to you in your handout. Osis means process, so that's just how plaque is formed. And some people say, oh, she's got atherosclerosis. Some people say, oh, she's got plaque. Same thing, it's just 2 different words, okay? So atherosclerosis is the process, how it is formed. All right, so do know that. Atherosclerosis is the process, what causes the plaque to form. Plaque is the material. So atherosclerosis has caused the plaque to form. Plaque's your material. And then what do you think the effect of having plaque in your arteries is? Can be. But what will happen is it will cause your arteries to close up. Remember the first day I drew the drawing? That was plaque in the artery, so it causes stenosis. Okay, it causes the blockage. So atherosclerosis is the process. It's what causes the material, which is your plaque. And then plaque causes the stenosis or the blockage. All right, this bad boy. So this is my artery here. The green stuff is going to be my plaque. So you can see how it's causing the diameter to get smaller, wider here and smaller within the plaque. So it causes a stenosis or a blockage, okay? That's what the plaque says. So know the difference between atherosclerosis, plaque, and then stenosis, what they mean. On chapter 2, we're going to go over different types of plaque, because you don't just find them. Now we got to know the difference. Some are more dangerous than others. And this handout right here, pretty much what you will need to study as far as the different types of plaque. This is what I'll text you on, so I summed it up a little better. But starting on chapter 2, Emily mentioned that the main reason we even scan carotid is because the patient had a stroke. Plaque has caused the blockage of the blood flow, which means that the patient's brain is not getting an adequate amount of blood flow to it, which causes them to have a stroke. So there are several different types of strokes, and there's different reasons. We'll go over the different types first. On page 33, you have what's called a cerebral vascular accident, CVA. That's a completed brain stroke. That means if that patient had a stroke and they lost feeling in their left arm, they're never going to get it back. Okay, it's completed. There's nothing we can do about it. Transient ischemic attack means they've had symptoms of a stroke, but they resolve within 24 hours. So I come in, I can't move my left arm, but within 24 hours I can. I've had a TIA, a mini stroke, is what a lot of people call those. Reversible ischemic neurologic deficit, which is a REN. They have symptoms that resolve, but they take longer than 24 hours. The time range is 24 to 72 hours. This book doesn't add that in. Okay, so a REN lasts longer than 24 hours, but less than 72 hours. So what do you think? Okay, so I've had a stroke. My symptoms have lasted greater than 72 hours. So what do you, it's no longer a REN. So what do you think the characterizing my stroke is now?
The CVA.
CVA, all right? Now the trick is, a year later, if it resolves, you fall back into the REN category. Even though it took longer than 72 hours, it resolved, so it's no longer a completed stroke. Your symptoms went away, all right? So CVA, symptoms last forever, never get better. TIA, less than 24. REN, technically 24 to 72 hours, but if a year later I resolve, now I'm back in the REN category, okay? And then also another possibility of having a stroke is death. Some people will never recover from stroke. Now you'll need to write in causes of the stroke. This book doesn't really mention them. One of them is a thrombus. Does anyone know what a thrombus is? Well, it's a blood clot. Okay? So a thrombus is a big cause of having a stroke. If a blood clot is lodged in a vessel, it blocks any blood flow from getting distal to that, getting past that. So if I have a blood clot in my ICA and it's caused my ICA to become occluded, then no blood flow can get to my brain, which would cause me to have a stroke. Okay, so thrombus is one. Embolism, do y'all know what that is? It's a traveling blood clot. It's a blood clot that has broke loose and it's gotten lodged in a vessel. So now, a lot of people think that an embolism is only a blood clot, but it can be a blood clot, it can be air, or it can be a foreign substance. So you got a knife fight, you got a shot, whatever, and part of that material was left in you, and now it's lodged in a vessel, depending on how ghetto you are, all right? So, embolism can be a foreign substance, air, or an actual blood clot. But thrombus just means blood clot. Alright, hemorrhage is another reason to have a stroke. Do you understand what hemorrhage is? You start bleeding within your brain. And then the last one is ischemia. Ischemia is loss of blood flow. Ischemia is loss of blood flow. So ischemia would mean that they have so much plaque built up in their artery that it's completely blocked it off. Alright? It's not a blood clot causing the blockage. It's not an embolism. It's so much plaque that now the vessel is shut off. Hemorrhage and ischemia are your most common forms. The most common reasons for having a stroke are hemorrhage and ischemia. Alright, so those are your different types of strokes, and those are some reasons to have a stroke. Ischemia and hemorrhage are your most common. Alright, a very important thing that we're fixing to learn is different stroke symptoms depict different arteries that we as techs need to be looking at. The first row, where it says common hemispheric, these are going to be strokes that involve the CCA, ICA, and ECA. So all these first sections that we're going to talk about, they involve strokes in the CCA, or blockage in the CCA, ICA, and ECA. Okay. So aphasia, and that's what, I'm not going to read all these because I know you know how to read, but aphasia is inability to speak. So if I come in and I cannot talk, you know y'all need to be looking at my CCA, ICA, and ECA. All right? Some more that you're going to go over, you'll see most commonly dysphagia. They can speak, they just can't put their words in a proper order, okay? Dysphagia, difficulty swallowing, and then on and on and on. Amaurosis celiac, the one almost at the bottom, that's where they have like a shade coming over their eye, right? So again, any of those first row of stroke symptoms means we need to be looking at the CCA, ICA, and ECA. And you're thinking, well, what else is there to look at? At the bottom, it goes over vertebral basilar symptoms. Now, I said a minute ago, in a few weeks, we're going to start scanning vertebrals. Malia and Lauren's already scanned vertebrals. So, if a patient comes in and they're having any of these symptoms, drop attacks, they're just falling down, but they don't quite pass out, or they are passing out, syncope, or they have vertigo or dizziness, anything like that, that tells us, okay, we need to be looking at their vertebrals, all right? So it's important to know the different types of stroke symptoms to let, now you're going to look at everything anyways when you do a complete carotid scan, but it lets you know you need to pay more attention to these arteries because they're having these symptoms. Basilars. You don't scan basilars during a carotid study. Only CT or an MRI can see basilars. Okay? But we will learn later on why it's still important that we know some different side effects of having basilar symptoms. Alright? So for now, just know if you're having any of the top row, you need to go C, I, and E. If you're having any of the vertebral basilar symptoms, we need to pay more attention to their vertebrals. Okay? So do read through those and kind of know the differences. I'm not going to teach you on all of them, but some of them I might throw out there. I know I'll throw out aphasia, dysphagia, AF, syncope, vertigo, drop attacks. I know for sure that those will come out. And then at the bottom, some other symptoms of having a stroke could just be headache, neck pain, or death. So anyhow, okay? So we went over the different types of strokes, different reasons to have a stroke, and the different stroke symptoms and what arteries you should be looking at. All right, if you'll turn on to the next page, strokes can come from different areas, all right? So if it's a thrombus or an embolism, it can come from the heart, so it could be cardiac in origin, or it could be carotid in origin. So the heart can cause you to have a stroke, or the carotid artery can cause you to have a stroke. That's all you need to know, right? So it can be cardiac in origin, or it can be carotid. All right, underneath the two pictures of the brain, I don't know if this, y'all use the same book in Vascular 3, so some stuff I have highlighted I don't need to tell y'all, so I'm going to read this for a minute, because I want to tell y'all this, and you're like, why is she telling me that? Okay, so going down to number 3, and then another reason, another cause of a stroke is a cerebral aneurysm rupture. So inside your brain, you have an aneurysm that ruptures, okay? And then it goes over the intracranial hemorrhage that's inside your brain. This is approximately 15% of strokes are hemorrhagic. And then a vasospasm, that is a narrowing of the arteries. Okay, so it's not that the arteries have plaque in them, it's just that they begin to narrow. They begin to get smaller on their own. That's a vasospasm. All right, is everybody good up to here? We're going to flip on over then. All right, there's a picture on page 35, kind of like the one I handed you out. So there it is again. It says underneath there, the anomaly is also known as the brachiocephalic, and that the vertebrals form the basilar, and the basilars supply the posterior hemisphere of the brain. Okay, kind of like I said, right before they go to the back of the head, they join and form the basilar. Now, what you need to know now is that there are branches that come off the ECA, and there's one branch that comes off the ICA. And a way for y'all to start telling the difference in an ECA and an ICA is to put color on them. ECA has branches that come off of it, so you'll have your vessel, and you'll have tiny little projections coming off. Now, even though the ECA has 1, 2, 3, 4, 5, 6, 7, 8 branches, it doesn't mean you're going to see all 8 of them. The most commonly ones you're going to see are the first one. So I'm fixing to tell you the branches off the ECA. You do need to know them, and you do need to know them in order. Okay? For test purposes. The very first branch off the ECA is called the superior thyroid. The superior thyroid is the first one. The superior thyroid. It's not in the book if you're looking. All right, the second branch is called the ascending. I'll let you get that and then I'll spell the next word. Ascending pharyngeal. P-H-A-R-Y-N-G-E-A-L. I think that's how you spell it. Anyways, ascending pharyngeal. Pharyngeal. P-H-A-R-Y-N-G-E-A-L. Right, the next one is called the linguinal. L-I-N-G-U-N-A-L. Linguinal. That sounds right. All right. Linguinal. Huh?
G-U-N.
I can't spell. I have to write it. Yes. L-I-N-G-U-A-N-A-L.
A-N-A-L.
I don't know how to spell. Anyway, it don't matter. If you see it, you don't got to write them. You'll see it. Linguinal. I know that's right, though, because it's null, N-A-L. But anyways, whatever. All right, the next one is the facial. I think we can all spell facial, right? Oh, Lord. So your next one is your facial. After that, you have the occipital. O-C-C-I-P-A-T-A-L. Yep. Occipital.
Correct. T-T, right?
Occipital. Yes.
Do these have a second word too?
Nope. There's a facial and then occipital. So you should have 1, 2, 3, 4, 5 branches. Y'all all got 5? Good. All right, the next one is the posterior. This is the first word, posterior, and then auricular. A-U-R-I-C-U-L-A-R. That's right. That is right. Let me write it. Auricular. Yes. Okay, so it's A-R-I-C-U-L-A-R. Auricular. Just like it sounds like whatever. Yeah, you said A-U. Well, it's auricular. That's right. A-R-I-C-U-L-A-R. Get on with here. I'm not no speller. Posterior auricular. Anyway, whatever.
If it's close enough.
Probably are. We're not in this book. Okay. Now, the next one is the maxillary. That's an easy one. Maxillary. And the last one is the super.
Is that right in?
No, there's 8.
Oh.
The next one is superficial temporal.
My little paper on that. Okay, what was that one?
Superficial temporal. All right, so we're going to go over them again. The first one is superior thyroid, then ascending pharyngeal, then the linguinal, how you spell it, then facial, then occipital, posterior auricular, maxillary, and superficial temporal. All right, spell them like you can, okay? I know I can spell either. So there's your branches off the ECA. So start using your color. If it has branches coming off of it, it's the ECA. All right? Like I said, you don't always see branches, and you're not going to always see all 8 of them. So just sometimes you can use that. Now the ICA has one branch that will come off of it, and it's called the ophthalmic. O-P-T-H-A-L-M-I-C. Ophthalmic. You will not see.
Yeah, could you spell it?
And yes, I can. O-P-T-H-A-L-M-I-C.
Okay, ophthalmic.
Ophthalmic. You will not see this branch. Okay. The only time you're going to see this branch is if you do a transcranial Doppler. So if you're, only time you're going to see it is if you're scanning the brain. All right? So don't be looking for that branch. So you have 8 branches off the ECA. Yes, you could see all of them doing an ultrasound. Mainly, you're only going to see the first one. And then the ICA has 1 branch that you will not see unless you're doing a transcranial Doppler.
On the in class, I'm sorry to go backwards. But
You're okay.
Ataxia, underneath the common hemisphere symptoms, on this, it says it involves blank arteries, so.
CCA, ICA, ECA.
Oh, yeah.
Yep. That's okay.
I even wrote that down.
All right, turning on, we're going to skip a few pages and go to page 38. All right, on page 38, we're going to look under different reasons that increase the patient of having a stroke, of having plaque in their arteries, and different things you need to be looking for. Things you need to ask your patient, first of all, what type of symptoms are you having? Why do you want to know what type of symptoms they're having? So you know which arteries to look at. Also, you want to know when they occurred and the duration. Why?
To figure out what category they're in.
Exactly, to figure out what kind of category stroke they have had. So you need to know what type and how long. Also, you ask them if they've had a heart attack. Why do we care if they've had a heart attack? What's one of the causes of stroke? Cardiac in origin. So if they've had a heart attack, it's important for us to know that. Hypertension, which is high blood pressure. Why do we care if they've got high blood pressure?
Because that strains the, doesn't it?
Well, kind of. It increases their chances of having plaque. It makes their arteries harden, which increases their risk. Also, diabetes. Diabetes is another thing that slows the process down, and it causes cells to start sticking together, which causes plaque. Okay? Smoking. Smoking is horrible for you. And so smoking also causes your vessels to constrict. Anytime vessels constrict, that leads to ischemia. Ischemia is a cause of stroke, right? Okay. Any sort of vascular operation. Anytime any surgery, period, increases your risk of having a blood clot. So they've had any sort of vascular surgeries or surgeries in general. We need to know, all right? And one that they didn't add on here is hyperlipidemia, high cholesterol. Hyperlipidemia, which is high cholesterol. That means their fats are increased, which causes them to stick together, which causes plaque. Okay? Hyperlipidemia, which is high cholesterol. So all those things can increase a risk of a patient having plaque in the arteries, which causes a stroke. All right, we got all that? It says next, this is any time, especially when y'all start clinicals and y'all start really working with patients, explain every procedure that you do and the approximate amount of time, because they're already probably really anxious about having it done. And so, you know, if you're going to do a carotid study, you don't got to say, I'm looking to see if you got plaque in your arteries, see if you have a stroke, blah, blah. But just say, you know, Dr. Fino's ordered an ultrasound of the arteries in your neck. I'm just going to check the blood flow. Take me about 15 minutes, or however long it takes you. Okay? It's really simple. Just let them know what you're doing. It says for doing a carotid study, because that's what we're talking about, to make them be supine, and you can either use a small pillow or you can just take the pillow out completely. And that just, if y'all scanned anybody so far that their eye and E is all the way up in their jaw, if you'll make them extend their head back, it stretches their neck out. So it's a little bit easier to get to them. Okay? Turning on over to page 39. It just goes over some different things that on this page that you shouldn't do, the way you shouldn't scan, and especially this woman at the bottom, the very first picture, her hand is way down here, so she is really stretching those muscles right there, which is not good. The very first picture at the bottom. See how far that neck is from her? Now the second one, she looks like she's brought the bed up to her, so she's not stretching as much. So do, and then it goes over like standing wrong, holding the probe wrong. Just show you some different pictures. So do kind of pay attention to how you're standing and how you're holding the probe. Even holding the probe wrong strains your muscles in your hand, leads to carpal tunnel, then you won't be able to scan because your hands are going to hurt so bad. Alright, so you can flip on to page 41. If anybody got counted off for their transverse CCA because they did not have thyroid in the picture, it's very important. That's your first picture at the very top, page 41. Of course, this is the entire thyroid, but you can see you have thyroid, CCA, then jugular. That's what I want in your image, okay? If you're not showing thyroid, you're at the bulb. So, thyroid has to be seen for CCA picture, all right? Then, of course, some of y'all are still having trouble with your bulb. If you are not sure that you're at the bulb, go up to where it's split, slowly come back down, round the joints back together, you're at the bulb, okay? Expect for your color flow to be red and blue in the bulb. Anytime a vessel divides, it causes a flow separation, so some of your flow is going to be red, and some of it's going to be blue. So expect that in your bulb. Don't try to get it all one color. Right. It says the bottom paragraph on page 41 that the common carotid artery is identified at the mid-neck. The transducer should be anterior, and the thyroid should be seen to the right. And then on the left side, depends on what side you're scanning on. Once y'all start scanning on the left side, then everything's going to be switched, okay? Because right now, thyroid, if you're scanning, thyroid's over here, right? Once you get to the left side, thyroid's going to be on this side, because everything's switched. So anyhow, we can kind of skip over that. Go to page 42. Does everyone know the difference between what proximal and distal means? Proximal always means closest to the heart, okay? So if I ask you, is the CCA or the ECA, which one's proximal? CCA or ECA? CCA. CCA comes up and divides into the E and the I, right? Well, proximal means closest to the heart, so my CCA is closer to my heart, right? That's what proximal means. On top of 42, it says scan proximally, then more distally to get to your bulb. Alright. The bulb, any bifurcation, but especially the carotid bulb, is the most common site for plaque to form. Alright. So if they have plaque in their ICA, expect to find it in their bulb also. Or if they have it in their E, expect to find it in their bulb. The most common place to have plaque within the carotid artery. Alright, going down to the middle of that page, it's got like different ways you can scan. You can scan from the anterior, you can scan lateral, or you can scan posterior. I know I helped a few of y'all. Y'all couldn't see the split very good, so I went more towards the back of the neck. So don't get used to staying on one part of the neck. You need to come more towards the front, or more the middle, or more towards the back, whatever, to make your image come in. So those are three different windows. It says right under there, it's got our underline. The best window for the ICA is usually from the posterior approach. Okay, so usually from posterior lateral, you're going to get your ICA in, and the ECA is more anterior lateral. If you think about it, anterior means closest to the front, well, ECA sits closer to your face than ICA. ICA sits closer to the back, so that's why it's posterior lateral. All right, at the bottom, differentiating the I from the E. To differentiate the I from the E and identify the ICA by its more posterior position in the neck, the ICA lies posterior in most patients. So in a lateral scan position, posterior direction is to the side of the field that's away from the thyroid. So that just means you're going to scoot back. Y'all know what posterior means, back of the neck, okay? That's where you're going to scan from. That's all you need to know about that. Just remember that ICA sits more lateral, just like the image on the top of 42. And the ECA sits more medial in most patients. Okay? That's the most common. ICA sits lateral, it's bigger. ECA sits medial, and it's smaller. Right, you can turn over to page 43. The last three bullets on page 43. It says a general rule of thumb is in transverse view is that the ECA will bifurcate towards the side where the thyroid is, so more towards the medial. And the ICA may appear more in the near field or the far field. but it's almost always on the opposite side of the thyroid. So you got your ECA being closer to the thyroid. In longitudinal view, if scanned from the same approach, the same relationship will exist. I've told you this before. If you got a tuna fork and the ECA is on top and transverse, it's going to be on top and long. Okay? It's the exact same thing. If your ECA is more medial and long, or in transverse, it's going to be more medial and long. It's the exact same thing, the way you found it in transverse. Now, the bottom one, in transverse, if while you're scanning up, the E and the I bifurcate far apart from each other, that means that they have a tortuous ICA. So while you're scanning up, if they bifurcate far apart, you already know this patient has a tortuous ICA. So that tells you right now, okay, this is going to be a little more challenging scan, because our ICA is going to probably do all kind of nice little curves for you. All right, turning on over to the next page. There's your picture of, good, so on top of 44, it goes over what the left side's going to look like. You can see how now the thyroid's on the opposite side of the screen. It's still medial, considered medial, but now it's on the left side, okay? And then it shows how the I and the E are. The ECA is still medial, it's still closest to the face, but it looks different because you're now on the left side. So everything just kind of switches around. See that? That's what it'll look like when you get onto the left side. We'll not worry about that till after midterm, okay? But that's what you'll see. Now some anatomy tips. It says the most common mistake in carotid imaging is the incorrect differentiation from the I from the E. And y'all are right there right now, not knowing if you're on the I or the E. The ECA is usually smaller than the I, but not always. It has branches that can help you differentiate from the I. ICA and ECA differentiation is easy in normals, but can become very difficult if they have disease, or they have a high bifurcation, or they have a tortuous ICA. Anything out of the normal is going to make your scan a lot more challenging. Doppler waveforms can help you differentiate from the I from the E. And I think we add Doppler next week, don't we? Yeah, we do. Okay? So y'all are going to start looking at the waveform and listening to them to help you know the difference between the I and the E. We'll get into that really next week on the listening. Okay, on page 45, nothing you really need to know from there. Nothing. So we're going to flip on over to page 46. Just remember, use a linear probe. You're doing arteries, so you want to be at 45 to 60 degrees, and you start Dopplering, okay? In this little box here, it says transducer rotation for I and E. In longitudinal, follow the course of the CCA. Now, I've told some of y'all you can do this, but I think where the stage is that you're now, it's easier to go up in transverse and then turn on it. But if you are steady enough to stay on the CCA and follow it straight up, you're going to land right in the ICA. Okay? So if you can do that, go ahead, but you've got to be sure you're staying steady on it. So that's what it's telling you to do. You can follow the course of the CCA to the bulb, keep the proximal end of the transducer over the bulb, and then pivot it. So you're going to go towards the face for the E, towards the ear for the I. Page 46 in that box right there. Alright, so if you want to start doing that, keep the CCA in long, follow it up, you'll see it get a little bit wider, that's the bulb. And usually if you'll keep traveling up, you're going to land right in the ICA. But if for some reason you don't, turn towards the face and get E, out towards the bed and get I. Alright, the next thing is two different ways the tune fork can look. ECA does not always have to be on top. Sometimes the ICA can be on top. So don't get used to seeing it one way or another. It can be either way. You can see in both of these images, the ICA has a little bit bigger bulb, especially in the second image. On the first image, their bulb looks almost the same size, right? It's slightly bigger, and it has slightly more of a curve to it, where the ECA goes straight across. On the first image, you can see how the ICA dives down a little bit, where the ECA comes straight across. Same thing on patient number 2. ICA curves, ECA comes straight. So we'll be looking for that, just a little bit of curve, and that's also going to help you know the difference between the E and the I. It says in the little box, and it goes pictures, you see the word wishbone. So another word for tuning fork is called a wishbone. And you think, we all know what a wishbone is, how it splits. That's where they get the word from. It says only about 15-20% of patients have a tuning fork, but I've always found that to be untrue because more than 20% of my clients usually have a tuning fork. So, don't, like I said, don't get used to seeing it one way or another. The last thing on page 46, tortuous ICAs are challenging to image. Imaging them in transverse is initially going to be very helpful. Again, because what if they decide to take far apart? You already know you have a tortuous ICA. It says it's very helpful, if not essential, in determining the course of the ICA. A major step in becoming a good carotid sonographer is the ability to transform what you see in transverse to what you find in long. So just keep that in mind. Whatever's going on in transverse, the exact same thing is going to go on when you turn your probe in long. Okay? Alright, we're going to turn on over. Page 47, the first three images, that's going to be Lisa and Jaleesa's carotid, which is why I took them out. I can't remember which one it is. I think it's Jalisa. Her carotid is the last one. I mean, it just goes straight down. So, we will eventually start scanning them, okay? But just not right now. Alright, so some other methods for telling the difference between the I and the E. Again, the ACA has branches, right? ICA does not. Well, it does, but we just can't see it. It mentions how the ICA has a lower resistance. Just go ahead and highlight that. I'm going to explain that to you in just a little bit, okay? The ICA is usually larger than the ECA, although this can be misleading because disease in the ICA will make it smaller. So again, don't get used to looking at the size of a vessel. So right now, I've told you, you can't look at the size, you can't look at the location. What in the heck are you going to look at? Tell the difference, right? So, I know. You can't get used to anything. This little trick is another thing you can do. It's called the temporal tap. It's used on the ECA. Alright? You will, it's called the temporal tap because you're tapping their temporal right there. And when you do that, it causes the ECA to oscillate. See where they tapped it in the picture? But guess what? You can't do it on everybody. Of course. Some people have a thicker bone right here, so it ain't going to work. So you can't always use that. Alright? But it is a tool that can be used. So the temporal tap is used on the ECA. It can't be used on the ICA. Alright. So that's it on that. Okay? Like I said, in just a minute I'm going to get to what the word low resistance meant, but we're going to get to that in a second. Now it goes into the bottom of 47, the different types of plaque. Like I said, this sheet right here, I would rather you go by that. So you can look in your book, but let's just go by the sheet right now. Okay? And I've got some plaques on my thing here. Alright. I'm going to sit down for just a minute so I can pull these up. But the word anechoic, y'all know what anechoic means, right? Completely black inside. So you have anechoic plaques. They're echo-free. It says you need color to see them. Alright, if you have plaque in the artery, when you turn color on, it's not going to fill in. So when I come through and say turn your color gain up, make sure the whole artery is filled in, that's why. Any part that don't fill in, once you start working, the doctor's going to think they have plaque in it. Okay? It's just anechoic. It's the same appearance as your vessel. Alright, so it's all just black in there. The next type of plaque is echogenic. Very bright plaque. That's pretty simple on that. You're not going to miss that. You're going to see it. Then you have hyperechoic. So hyperechoic is brighter than the surrounding tissue. So we've all seen the muscles, because I've told everyone to stand out in no man's land. You've seen those white muscles. Echogenic plaque is brighter than those muscles, that tissue. It's really, really bright. Like I said, it almost appears white. Then you have hypoechoic, similar to anechoic. It produces very low echoes, and it is more likely associated with symptoms. So you need to know that. Hypoechoic plaques are more likely going to cause symptoms than these other ones. Alright, heterogeneous, it has mixed echo patterns, so some of it might be really bright, some of it might be really dark. Alright, so heterogeneous is mixed echo pattern made up of different types of plaque, and it's a high-risk lesion. Because it's made up of so many different types of material, it has a higher chance of breaking off and forming an embolism. Right? So know that. Hypoechoic causes more symptoms, but heterogeneous is more dangerous. One of your high risks.
Heterogeneous causes more, it's more dangerous.
It's more dangerous. I cannot believe I don't have any of these saved. Alright, the next one is homogeneous. So it has a very smooth texture. You can see it was inside of the vessel, but it looks like a thyroid texture. Very smooth. I guess I haven't saved for some reason. And then the last one is calcified plaque. It's very bright. Now the difference between it and hyperechoic is calcified produces shadows. Calcified is bone, not really bone, but calcium that's stuck together. So it shadows out everything below it. Okay? Because of that, you cannot Doppler You cannot Doppler underneath calcified plaque. You can Doppler under every other type of plaque, but you can't Doppler under calcified. Because of the shadows, the ultrasound beam won't transform through it and all that physics stuff. And it is also a high-risk lesion. Made up of the hard material, breaks off, causes an embolism. I'm so mad at myself, I don't have that saved. Alright, so those are your different types of plaque. I want you to know those. On the back, it just shows you a picture of what plaque is. There's a normal artery, there's a little plaque in it. When a vessel does have plaque, you do have to look at it in long and transverse. Okay? So I'm going to get a little bit ahead of my book for a second because we're talking about it. But if I'm looking at my artery in transverse, so let's say I'm looking at the ICA, alright? And it has plaque from here down, alright? You have to be able to measure this. And the way you do it is you will measure what's called the true lumen versus the residual lumen. Residual means what's left. So in transverse, you have to measure the true lumen versus the residual lumen. Alright, so my true lumen would be from here to here. Okay, so the whole length, the whole width of the vessel. That's my true lumen. Alright. And then my residual lumen, I put the same marker up here and I go to there. Okay, so I'm measuring the whole thing, and then I'm measuring what's left, and it gives me an average. So to me, this looks like this would be about 40% blockage here. I'm just guessing. So true lumen versus residual. That's how you measure a stenosis of blockage in transverse. But then when it's in long, I'll draw it over here. So now I've got my artery lengthened out. I've got my plaque going here. Here and here and here. Now, the difference is when you're in long, now we put our stick in there and we Doppler it, okay? So, in transverse, you're actually going to measure how much plaque is in there. True lumen versus residual. And it'll give you about, let's say it gave me 40%, alright? When I Doppler in long, different velocities correlate to different amounts of plaque. So let's say a velocity of 130 means they should have 40 to 50% of plaque in there. So if I'm saying they got 40% blockage, then I need to get a velocity around 130. Okay? And next week you're going to get the chart for this. I'm kind of ahead of myself. Velocities do not increase until you get over 60% blockage. Y'all need to know that. So a velocity will not increase until a blockage gets over 60%. Velocities will not increase until you get over 60%. So it's very important that these images match. Okay? If I turn this into a Doppler, and in transverse on my images, and I'll say, well, this patient has a 70% blockage in transverse, but then my velocities come out normal, they don't correlate together. So they have to work together. If this patient has a 50% blockage, then my velocities are going to be normal because they don't increase till you get 60%. Alright, so those two things are going to work together when you're measuring how much plaque is in a vessel. Now, some techs, and it just depends on where you work at, some techs or some radiologists will ask you to measure from here to here. Okay? So, it just kind of depends on where you work at, but you're always going to do the true lumen versus residual. You're always going to do the velocities, and then some might add in that one more measurement right there. And every machine is set up to calibrate it, so you don't got to figure out on your own, is that 50%. The machine, once you plug those numbers in, it'll tell you it's 50%. Okay? So those are just some ways that you're going to, when you start looking at plaque, that you will be measuring it. And I think that's where it starts on, at the bottom of 48. You can see a picture on the bottom of 48 of them measuring a vessel in transverse. It's a true lumen, then they measured their residual lumen, and it gave them 50%. Again, the machine just figured it up. You don't have to do that. So the residual lumen is the diameter of the vessel that is left open, the part that is not blocked by a plaque. Alright, the very last thing on 48, it says diameter measurement, which is this, a diameter measurement provides a ballpark estimate of the degree of stenosis, but is considerably less reliable if the stenosis exceeds 60%. At this level, the residual lumen becomes progressively more difficult to discern. So it's saying the more blockage that's in this artery and transverse, the harder it's going to be for a tech to tell what's open and what's not. So it becomes, this kind of measurement becomes less reliable once the stenosis gets over 60%. Alright, so if this becomes less reliable, that means this is going to become more reliable. So once you get over 60%, diameter measurements become less reliable, but Doppler measurements become more reliable. Okay, so once you get over a plaque, that's 6%, you're going to do this image, but you're going to focus more on what this is going to give you. What are your velocities? Because they increase once you get over 60%. Alright? So way to remember it, if it's less than 60%, diameter is the best option for measurement. When it's over 60%, velocity, Doppling it, is your best measurement. Diameter is used for less than 60%, Doppler is better for more than 60%.
Now, will they, if it's less than 60, do they want you still to?
Oh yeah, you still get it. You still get it, but remember these don't increase until you get over 60%. So you're going to have normal velocities even though you have 50% stenosis. So that's why it's more reliable, less than 60%, because your velocities are not going to increase until you get over that. So you're still going to do all of it. It's just one's better than the other depending on how much blockage there is. Alright, turn on over to page 49. The second little arrow, it says that diameter measurement in longitudinal. So like I said, some doctors will want you to do the longitudinal little measurement. They can be done, but it says they miscalculate the stenosis. Okay, so it's not very common, but just some old school radiologists want you to do old school stuff. So it can be done where they can measure that. Alright, I've got to show y'all this, it's driving me nuts, so give me a second. It's stand to talk about something I can't show it to y'all. Like it's really making me nuts right here. Turn this Come on, slow, let's go. There it is. Alright, so I'm going to show you the different types of plaque because I cannot go on until I do. It's just not going to work. Let me find the good one.
What is it?
I used to show these, did like the lemon.
Well, nothing online, I don't know where they're at.
Only 20%.
Where
So
are
the
they?
pharmacist told me to use for Kelly routine.
Optimized.
But I bit my lip and I swelled.
Mm.
Protection.
Okay. Y'all give me just a few minutes, please. I'm gonna find these before I go again.
I mean, it wasn't like a
Take a few minutes, chill out, we'll find them.
I need a minute.
In the meantime, can I ask a question?
Yeah, go ahead.
Okay, on the in-class assignment, the ICA normally sits blank to the ECA. Would that be talking about lateral?
So it's lateral?
Lateral.
Okay.
Because it says in there posterior on the one.
Well, posterior lateral,
Okay.
either one works.
So both. Yeah.
Chemo, chapter 1.
That's what I said. This one's confusing.
Oh, well, we're not gonna do that, I can't find him, take me a minute. Okay. Well, if you look on page 48 real quick, there's, a picture, the only type it's showing in this book right now is on page 48, that first picture. That is heterogeneous plaque. You can see how some of it's bright, some of it's dark, okay? Another word, for heterogeneous is irregular. Right, so another word for heterogeneous can be irregular, which means it's made up of different stuff, all right? And then, another word for homogeneous is smooth. And I think I mentioned that in the little handout, smooth, even texture. All right, so, and it didn't show us anymore. Now, calcified would be all that bright white stuff. It would just be one solid white, and it all shadows underneath it. All right, and I'm gonna find some before we have class next week, because that drives me nuts. All right, so look on page 49. 49 goes into using color when you're looking at these vessels. So it says color Doppler is used to locate a region of a stenosis or flow disturbances and allows placement of the Doppler sample gate. You want to put your sample volume or your angle correct. You want a Doppler in the tightest area of stenosis. All right. If you use color, we know the arteries normally come in red, right? So where the area is the tightest, you're going to get more like a yellow color. So the brighter the color, remember we talked about last week, faster flow is brighter, all right? Velocities increase in a stenosis, so that means they're going faster. So the brighter the color, that's where you want a Doppler at. So if you got a color that's red, orange, and yellow, Doppler in the yellow, that's the brightest color. Faster flow is brighter. Velocities cause faster flow. And you want a Doppler in the tightest area of stenosis. So find your brightest color. So color Doppler is essential for Dopplering a vessel, Dopplering a stenosis. You've got to have color on. And that's what it says. It is essential for determining whether flow is present or absent, and it's helpful in following the course of the vessel. Color Doppler has been shown to improve accuracy and differentiating very high-grade stenosis from a total occlusion. If it's totally occluded, guess what? Not going to fill in with color at all. So anytime the high-grade stenosis, which is more than 95%, as long as a vessel is not completely occluded, they can do surgery on it. I may have mentioned that before, I don't remember. But even if the ICA is 99%, they can do surgery on it. Once it gets 100%, no surgery, which means the patient is just out of luck because they're not going to get any blood flow to that side of the brain unless they put in a bypass graft or something. So it's very important. Once you get over 95%, you have what's called trickle flow. Imagine this vessel's almost completely closed, so it's got flow through it, but the opposite happens. Now you have very low velocities and very low color flow. So So once you get over 95% stenosis, you fall into the trickle flow category, which means you have very little flow running through there and very low velocity. So expect high velocities up to 95%. Once you get there, the opposite will occur. Okay? And so, of course, you're going to need to use color to see if you have any flow going through there. All right? What did we talk about last week? If color Doppler don't pick it up, what else can you use? Exactly, power Doppler. So don't use color and say, oh, well, they don't have flow. Make sure and use power, because, again, even if it's 99%, they can go have surgery. And that is easier to have an artery cleaned out than to have a bypass graft put in. Okay?
You said even if it's 99.
I'm just saying, even if it's 99%, they can talk. Once it's 100%, game over. Okay? So over 95% stenosis, so it can be any artery in your body. It don't have to just be an ICA. You have what's called trickle flow. So yes, there is still blood flow getting through there, but it's very minimal, so it causes very low velocity. Color and Doppler are essential for detecting this flow. The next little paragraph, although color Doppler can identify the flow changes associated with a stenosis, it cannot quantitate the stenosis. During the color Doppler exam, the following controls are frequently adjusted. So what that means, it can't quantitate. Yes, it's telling you there's a stenosis there, but it can't tell you how much it is. Okay, so use it to find the tide of stenosis, but it can't tell you how much is there. It can't give you velocities, and it can't give you percent. So I think some of y'all have realized just doing normal color so far. What are some things you've had to change? You've had to turn up your color gain.
Invert it.
You've had to invert it. You've had to mess with your scale. So you're constantly adjusting. You've had to turn your box. Different things. And that's what it says. Some things that you're constantly going to be adjusting. Color, velocity, and scale. Color gain. The steering of your vessel. The steering of your box. And then it goes into what all those things mean on page 50, but I think y'all know what all those mean. Okay. If you don't, there they are. Okay? So don't, I don't know if many of y'all have messed with color scale yet. The lower you bring your scale, the more color is going to fill in. But if you bring your scale too low, what happens?
Oh, alias.
Aliasing happens. If you bring your scale too high, that's when it won't fill in. So my advice is to turn your color gain all the way up until it goes everywhere, then turn it back down. If you're still not getting good color fill in, bring your color scale down until it goes everywhere, and then bring it back up. So adjust both those things to the point to where they're just aliasing everywhere, and then you can fix it from there. All right, on page 51, it goes over color Doppler protocol. Then y'all have done some of this. The entire CCA should be evaluated with color Doppler. So far, y'all have just put color on the CCA, but you will eventually have to fill in the entire CCA. The bulb and the proximal ICA should be looked at with color. Okay. I have said, and I probably wrote on your paper, lengthen out vessel, keep vessel lengthened out. You want to have it. Most of the time you're going to have just a little bit of the CCA, then you're going to have the bulb, then the I and E, whichever one you're looking at. You want it lengthened out all the way across the screen. Okay. And that way you can show color with bulb and I and bulb and E. In the bulb, you have an area of flow separation, which I mentioned a minute ago. It's called eddy flow, so it's going to come in red and blue. You're not going to have just one color. Absence of color filling may be due to plaque, low velocity flow, or a poor Doppler angle, or your color gain is too low, or your color scale is too high. Those are just some other reasons. Also, y'all have just been looking at the I and the E, but you're eventually going to have to Doppler the ICA from proximal, mid, and distal, where it goes all the way up to the head, as far as you can go. Same thing with ECA. You do prox, mid, distal, follow it into the face. We'll get to that. I don't know, y'all will get to Discord, but it will be coming up. So you look at the whole E and the whole I and the whole C and the bulb. Everything you look at with color. Vertebrals, look at with color. You're going to add those in. Any region of flow disturbances should be recorded. So we know the bulb is supposed to have that flow separation, but the C, I, and E should not. Okay? So it's supposed to be all solid red in there. If you're getting orange or yellow, what does that mean? Huh? got fast velocities, which means probably there's a blockage in there causing those faster velocities. So you need to note that. Even if you don't see it, you still need to make a note. You know, in the area of the mid-ICA, I noted high velocities with color Doppler. However, with spectral Doppler, velocities were normal. This kind of covers your tail and makes you seem like a really good tech. So, anyhow, I would do it. All right, the next thing is total occlusion of an ICA is suspected. The artery should be interrogated with low scale for trickle flow. When you Doppler a vessel, let me show you real quick. All right, when you're Doppling a vessel, you don't want to have a little bitty waveform. This is a horrible waveform, but just take it. And then your scale will be on 140 up here or something like that, okay? So you want your scale to fit your waveform. Because if you have a little waveform and a big up scale, and once you bring your scale down, it makes your waveform look bigger. All right, so pay attention to your scale and the way that your waveform looks. Because if your waveform's too low, then what happens? You start to alias, right? So you don't want to have a big old scale and a little bitty waveform. You want it to look pretty, just like your images. So watch that. But if you have trickle flow, that means you have a 95% stenosis or more. So you have very little flow, so you're going to need a very small scale to even pick up that flow. Okay? When y'all start Dopplering next week, that's something that we'll really start working on. The waveforms, the scales, and if you're having trouble picking up your waveform, bring your scale down. Okay? If your scale's too high, it won't pick it up. We talked about how power Doppler should be used. We're not going to go over that again. Now, Dopplering of stenosis is next. So we have a lot to talk about. Oh yes, we're just going to keep on going. All right, let me draw my stenosis. Just keep it up here. Ooh. Okay. I just always put my stenosis here. It's not always going to look like this though. Okay? It's going to be crazy. Alright, when you're Dopplering a stenosis, you have to Doppler before it, which is proximal to it, within it, and distal. Alright, so when you Doppler a stenosis, you Doppler proximal to the stenosis, proximal to the stenosis, within the stenosis, and distal to it. Proximal, within, and distal. And you're Dopplering a stenosis. No matter if it's 20% or 90%. This is how you're going to Doppler it. Proximal, within, and distal. Okay, there's certain changes that will go on with the waveform, depending on where you're at. Proximal to a stenosis, your flow is considered to be dampened. Alright? So proximal to a stenosis, your flow is dampened. What that means is the normal velocity for an artery is about 120. Dampened would mean it'd be about 80. Okay? The waveform still has the normal characteristics, which we'll get to, but it just has a lower velocity. The normal velocity, like I said, around 120. If you have a waveform that looks good, it just has a lower velocity, it's called dampened. So proximal to a stenosis, you should find dampened flow. Your waveform is still beautiful, it looks good, it just has a lower velocity. Okay, dampened flow. We talked about this on the very first day. Why? Okay, why is flow proximal to a stenosis dampened? Why does it have lower velocity?
Resistance.
You remember talking about that?
The water spout soon.
Exactly. What if your velocity is down, what two things are up? Pressure and flow are up, velocity and resistance are down. Okay, so we're in, our vessel's completely open proximal to the stenosis, right? So our pressure and our flow are good to go. but our velocities and our resistance are down because they have no reason to be increased. So dampened flow means lower velocity. So I said that little thing I gave you on the first day, you need to know it. You need to understand it from here on out. That's why you have dampened flow. You have lower velocities because the pressure in your flow are increased. Now, once you get inside the stenosis, what do you think happens? What goes up? Velocity and resistance, and pressure and flow go down. So you should expect increased velocities within a stenosis. All right? Increased velocities within a stenosis. But here's the little tricker. At what percent of stenosis do you have to have increased velocities? 60%. So it don't matter if this is 40% stenosis, your velocities are going to be normal. Okay? So you only have increased velocities within a stenosis once you get to 60% blocked. And then, we talked about this last week. What happens distal to the stenosis? What form right here? The turbulent flow. Yep, you got it. It's called post-stenotic turbulence. Remember I was talking about that? Post-stenotic turbulence. So if I was Doppler, that's probably not parallel, but anyhow. If I was Doppler, the stenosis, proximal, within, and distal to the stenosis. We'll have dampened flow here because of the lower velocities. Now we're going to have increased velocities. Now we're going to have post-stenotic turbulence. But it's got to be over 60% for any of those three things to occur. If I'm Doppler and a stenosis of 20%, I'm going to have normal velocities here, and normal velocities there. Everything's going to be normal. Right? But at 60%, that's when those things are going to start to take shape. I'll just use that word. All right, does everyone understand this part right here? All right, one more thing that you will add in. So you've Doppler proximal within and distal, but now you have to Doppler the stenosis 3 times. So you've already got one measurement, you just add 2 more in there. So you Doppler 3 times within the stenosis. Oh, that's horrible there. Anyway, okay? So you actually Doppler it 5 times. You actually Doppler stenosis 5 times. Proximal, within, distal, then you got Doppler within it 3 times. Okay. All right, so we know when we find the stenosis, it's important to know what type of plaque they have, right? You know if it's high risk. You've got to know the percentage, so you've got to measure in transverse. And then your velocities have to match your transverse measurement. If it's less than 60%, we got normal velocities. Once we get over 60%, we have increased velocity. And no matter if it's 10% or 100%, not 100, but 99%, you still got to do all those measurements, all 5 of them. Okay? But you just want to expect anything to be increased unless you get over 60. All right, and that's what it says at the bottom of 51. Velocity accelerations on number 2 occur when a stenosis reaches 60%. See that on number 2 at the bottom of 51? Velocity accelerations occur once you get 60%. Both on number 3, velocities do not significantly increase to a lesser degree of stenosis. There it is. All right, number 52, number 4. Most stenosis of 60% or greater cause significant turbulence distal to the plaque. This is called post-stenotic turbulence. So we said it right there. We should find post-stenotic turbulence once you get over 60%. Number 5, a focal velocity acceleration over the plaque followed by turbulence is an essential finding for, this says 50 to 60, mark out 50, for 60% stenosis or greater. We're just going to stick with 60. So if you turn in if you're doing a Doppler study and in transverse you say 72%, then that means you better have some increase, you better have dampened flow, increased velocity, and post-stenotic turbulence. If you don't, it doesn't correlate. Same difference. If you have, if you're saying in transverse is only 40%, because but then you have standard flow, increased velocities, and postmortem turbulence, then you know your transverse image wasn't correct. So they got to go together. And please make sure they do, so you won't get your tail chewed out like I did. All right. The next little paragraph under number 6 says the spectral Doppler exam complements the sonographic assessment and is used to determine the present location and severity of lesions. 60% diameter reduction or greater. If a stenosis is less than 60%, again, there is no velocity increase. Got it? So in a carotid study, week 1, grayscale. Week 2, color. Now we're doing spectrum. All that is what you'll do for a carotid. It includes all those different variables. All right, now we're going to go over some different types of flow patterns. And the first one is the CCA, which is at the bottom of page 52. It's second little sentence. It says flow in the CCA is usually low resistance. A low resistance vessel means a vessel that requires a lot of blood flow. Okay? Low resistance means that artery needs a lot of blood flow because of whatever it's feeding needs a lot of blood flow. So a low resistance vessel means they need a higher flow rate, higher flow volume. Low resistance requires more blood flow. And then the other is high resistance. If you're high resistance, then guess what? You don't need a lot of blood flow. Okay, you've got a lot of resistance pushing back, a little bit of blood flow is needed. So low resistance vessels need a lot of blood flow. High resistance, they need some, but it's not as much. Okay? So if you had to think about the I and the E, we know the I feeds the brain and the E feeds the face. Which one of them's high and one of them's low? Okay? Which one do you think is low resistance?
The brain.
ICA, because it's feeding the brain. Your brain needs more blood flow than your face. Okay? So there you go. There's your first step. ICA is low resistance. ECA is high resistance because ECA is feeding the face. So it doesn't need quite as much blood flow. But on the CCA, back where we're at, flow in the CCA is usually low resistance because it's feeding the E and the I. It needs a lot of blood flow to get to it, so it can get to those. The waveform pattern appears, it says a combination of the E and the I. So when you're Doppler in the ECA, it has very high peaks. Okay? ECA has very high peaks, which we're fixing to get on here. And normally the ECA does not have a lot of diastolic component within it because it's high resistance. It doesn't have a lot of diastolic flow. The ICA has a lot of diastolic flow. So on the CCA picture, you can see the high peaks of the E, and then you see all that diastolic flow. Y'all know what diastolic flow is? No? I know? All this stuff left right here is diastolic flow. Okay? So it's got very high peaks systolic, such as the E would have, and then it has a lot of this left here before another peak occurs. That's diastolic flow. So the CCA has combinations of the E and the I. It has the high peak of the E, and it has all that diastolic flow of the I. So it's a little combination of both. Why? It's feeding both, okay? Now, it says that the proximal CCA may be more pulsatile. Proximal means what? Closest to the heart. So why do you think it's more pulsatile? It's picking up vibrations from the heart. Exactly. Any vessel that's closest to the heart is going to be more pulsatile. The next thing is on 53, and it's the bulb. Now, we talked about how the bulb has that flow separation. If you Doppler the bulb, you're going to get like this image. You're going to have flow above the baseline and below it. And that's that flow separation. Because in color, it's picking up red and blue, right? We know red means arteries, blue means veins. We also learned that arteries are on top of the baseline and veins are below. So your machine doesn't know if it's an artery or a vein, it thinks it's both. So it picks flow up above the baseline and below it. It's called the flow separation, right? Because like I said, your machine has no idea if you're an artery or a vein. So the CCA widens just before the bifurcation, and before it extends into the proximal ICA. There's a flow separation. It's often called a helical or helical, however you say that flow pattern. And this is normal and should not be confused with post-stenotic turbulence. Post-synodic turbulence looks just like the bulb. So, if this is a 60% stenosis and I have post-synodic turbulence, that's what type of flow I should see. Above and below the baseline, just going crazy, it's going everywhere, right? So post-synodic turbulence just looks just like the flow separation picture. Now, next is the I and the E. If you look at the difference, you can see how the ECA has much higher peaks, y'all see that, than the ICA. And normally, it will say that the ICA has more of a diastolic component. I don't like this picture very well because it looks like the ECA has just as much as the ICA. Alright, but technically, the ICA is supposed to have more diastolic flow because it's lower resistance. It requires more blood flow. So, it says under proximal ICA, distal to the bulb, flow should be low resistance. And there should be forward flow throughout the cardiac cycle. Alright, so to explain that to you real quick. Once the heart, we know once the left ventricle contracts, it squeezes blood out of the heart, causes your blood pressure to rise. Once it gets fully closed, that's the high velocity, because as fast as your blood's moving. So, blood's coming up out of the heart, here it's completely, right here it's called the peak systolic, that's when it's completely closed. Then as the heart starts relaxing, your blood pressure starts falling, alright? And it's still continuing to open up, it falls below the baseline. Once it gets completely open, you have what's called this, which is diastolic flow. That's when your blood pressure is the lowest. That's when the heart is completely open back up, alright? So heart's starting to contract, completely contracts here, it's called the peak systolic velocity. Now our heart's starting to relax, our blood pressure's dropping back down, it drops below the baseline. Once the heart's completely relaxed, pick up what's called diastolic flow. Then the same thing happens again. Heart contracts, starts another beat. Okay, the same thing happens again. And that's what you're picking up when you're Dopplering, okay? So, this kind of waveform is called triphasic. It goes up, it comes down, it goes back up again. That's called triphasic. That's what normal arteries should look like. Normally high resistance arteries, I should say that. Alright. What happens on the ICA never comes below the baseline. Alright? So that's what it just said right there. It has a forward component throughout the throughout the contraction, I think what it said. So it never comes below the baseline. So that's what you have for the ICA. You know, I can't draw, but anyhow. Alright, so ECA goes below the baseline, ICA does not. So that's another way for y'all to start looking at your images. Which one goes below the baseline, which one does not, okay? Is it always going to be true? No, but for the most part it is. Another thing it mentions in this book, you can see how the ICA does not touch the baseline, but the ECA does, okay? I've found that to be about 50-50 on that, but you know, you can look at that too. ICA will not touch baseline, ECA will touch baseline, okay? And then look at your waveform. Which one comes below the baseline? ECA comes below, ICA does not. Because ICA is low resistance, so it needs a lot of diastolic flow. This is considered early diastole right here, alright? So if this needs more diastolic flow, it doesn't have time to come down here. It just relaxes a lot sooner. That's how the heart works. Y'all going to start to find out the heart works. Okay, so we've got our CCA, we've got our bulb, we've got our I, we've got our E. Does anyone need any of that to be gone back over? CCA has what components of the E and the I? High peaks of the E, diastolic flow of the I. The bulb has the flow separation. ICA, it has more diastolic flow. It's not supposed to touch the baseline. If it don't touch the baseline, guess what? It can't go below the baseline. Okay. ECA has higher peaks, less diastolic flow, and it comes below the baseline. ICA is low resistance. You need more blood flow to feed your brain. ECA is high resistance. You don't need as much to feed your face. Then, the next thing, it goes into the vertebrals. We talked about how they are a branch off of the subclavian, right? All I want you to know is they have low resistance flow similar to the ICA. That's all you have to know about that right now.
Could you repeat that?
Yes, vertebrals have low resistance flow similar to the ICA.
Thank you.
Very well. And of course, it's a branch off the subclavian. Vertebrals are low resistance. What do vertebrals join to form? The basilar. What do basilars go into? The back of the head. So why do vertebrals need to be low resistance? Because they're feeding the back of the head. Okay? So they're going to be low resistance. And don't worry about subclavian right now. Okay. Let's see, there's anything on this page we need to read. Go down to the bottom of page 54. See those images on the bottom? One of them, you can see how, we talked about last week the spectral window, I think we did. On the very first image, their gain is so high. This is the spectral window here, this inside, okay? You can see on image number 1 how it's all filled in, but image number 2, it's not. When the window's filled in, it's called spectral broadening. I know I mentioned that last week. Spectral broadening represents turbulent flow. So if you're turning in an exam and it has spectral broadening, you're saying that patient has 60% or greater stenosis. Because when does velocities increase? At 60%. So when does flow become turbulent? At 60%. Okay, so if you're turning in an image like that, you're telling the doctor this patient has a 60% or greater stenosis. When really it could be that your Doppler gain is too high, and you just need to turn it down. I'm joking. And that's something we'll work on next week also. You want that spectral window to be open. Okay, and on page 55, it talks about how when your Doppler and velocities are the important information, you don't want to go over 70 degrees. I know we mentioned that last week. I said if you just need to show they have blood flow, you can use any degree you want to. But if you've got a Doppler velocity, don't go over 70 degrees.
I thought it was
60. Yeah. But you can use anything over 60 if you just want to show they have blood flow. This book just mentions 70. It don't do 60 between 70 for some reason. Alright. So only use it when you need to know they have flow. We know to stay 45 to 60. This book says 50 to 60. Mark it out at 45. It's in the very second paragraph, last sentence. 45 to 60, what you want to Doppler within. We've done talked about mapping of stenosis. Not going to talk about that. What is in those 5 bullets is what I've had drawn on the board for y'all, okay? Proximal within distal, and then Doppler 3 times within the stenosis. We know to expect dampened flow proximal, increased velocities within, opposed to not turbulence after, but it only happens when we're at 60% or more. Okay, you can turn over to the next page. Here's a good example. The first 3 images are a stenosis that's less than 50%, so they have no turbulence. Their velocities, everything's normal about that picture, okay? The next pictures are 50 to 69%. Now look at the very first picture. You see how the ICA is no longer red? It's green, yellow, purple. So you want a Doppler in the yellow, the brightest color. And that's where you're going to pick up your highest velocities. Alright, now look at the second picture, proximal. They're saying proximal to the stenosis. You see how their waveform looks normal, it's just dampened. It's only 80 centimeters per second instead of 120. Okay, so it's dampened flow proximal to a stenosis. And then the next picture, they're within the stenosis, and now their velocities are 237. So they have increased velocities because of the stenosis. They got over 60% stenosis, and it's called dampened flow proximal, increased velocities after. Y'all see that? And their color helps them know this patient's got very fast flow there, so that's where we need a Doppler at. And of course, it doesn't show post-synodic turbulence in that, but they will also have that. on the next page, now we're into even higher stenosis. It's showing you some more pictures. You can see the plaque in the very first image, see the white. That looks like calcified because it looks like it's shadowing down. So you couldn't Doppler underneath that. Then when they turn color on, you can see the area where the region of plaque is. See, there's very little color flow going through there. All right, but then past it, you've got green and yellow, so we need a Doppler in that area. They're showing the next is the CCA, that's proximal to the stenosis, so they have dampened flow, 69 centimeters a second. Yes?
Hey, Carmen. Can I take Malia?
Malia?
Uh-huh.
Malia. Then the next pictures again, Doppler and proximal to the stenosis. Then they get within the stenosis, high velocity of 354. And then look, post-stenotic turbulence. See how it looks like the bulb, it goes above and below the baseline? So that's what you're wanting to see when you start Doppler in these velocities of more than 60%. All right. Next, on 58 is a 95% or greater stenosis. We said that was trickle flow. So you would need to use a low scale and color or power Doppler to be able to pick that up. And if there's anything else on that you need to know. The next thing on page 59, still talking about trickle flow and using color and power. So I think I've drilled that in enough. Low scale, use color, use power, pick it up. Right, next is going into an ICA occlusion. Lord have mercy. I don't buy too much. All right. ICA occlusion is more important than ECA. An ICA feeds the brain, ECA feeds the face. Yes, both things are important. You know, some people's face is more important than their brain. So, but the reason that the ICA is more critical is because it doesn't have all those branches. The ECA has all those branches that if it becomes occluded, the ECA branches take over and supply the face. Okay? So ECA has all those branches. So what if the ECA becomes occluded? Those branches will take over and feed the face. But if the ICA becomes occluded, it doesn't have any branches, right? Not really. It has about one, but it doesn't have enough to take over the amount of blood flow that is needed because it's low resistance. So ICA is more critical than an ECA. If a patient has an ECA occlusion, they're not having surgery. If a patient has it, of course, they can't. Yes.
Is that when their face sags?
If they've had a stroke on their face or something like that, yeah. Even if a patient has a stenosis of 90% in the ECA, they're not getting surgery. They're just going to let it occlude, let the branches take over. But we know in ICA, we want to find it before it becomes occluded. Okay? Some ways to tell if it is occluded: use color Doppler, then use power. Have a low scale so you can pick up those trickle flow situations. You want to sample all the way through the ICA because the proximal part may be occluded, but the mid and distal will be open. So Doppler the entire region of the ICA. It says that the ICA may become contracted, and we mentioned that in the beginning. Normally the ICA is bigger, but if there's disease in the ICA, it starts to contract and become smaller. So that's another thing you can look at if you're trying to rule out an occluded in the ICA. All right. All right, page 61. Here's the pictures of some calcified plaque. You can see, especially in the color image, how it blocks blood flow. It blocks everything. There's no signal can get underneath that. You cannot Doppler underneath calcified plaque. Okay? If calcified plaque is on the lower wall, like it is on the first image, well, you can Doppler on top of it. I mean, that makes sense. It's not, you can Doppler on top of the plaque, but you can't Doppler underneath it. Okay? Let's see. Like I said, this book is used for 3-2, so some of this stuff I don't have to really tell y'all right now. On page 63, it goes into an ECA occlusion, and the very first sentence, this rarely occurs due to the numerous branches. So we're not going to worry about it. A lot of places don't even Doppler the ECA. So it's so unimportant, and the branches will take over. The next thing is a carotid dissection. And sometimes carotid, or any artery, doesn't have to be carotid, they have a tear in them. Okay, did we talk about the layers of the artery, intima, media, and adventitia? We've heard of it before, we'll get to it. What'll happen is the intima will tear, and it allows blood flow to get into the media. Alright, and it's called a dissection. It's normally caused by trauma. You got stabbed in the neck, like I said earlier, or maybe you had a car wreck, someone hit you in the neck, whatever. Whatever, some sort of trauma. It doesn't just happen on its own, okay? And it'll cause a tear in the intima. You'll know the patient has a dissection by two things. Number one, the very bottom pictures. Their arteries are now red and blue. What's happening is the blood's flowing out, making it look like a vein, flowing back in, making it look like an artery, okay? So you're going to have red and blue flow. Another thing is veins have what's called valves in them, and they're little white flaps that open up and down. Arteries do not have valves. A dissection without color looks like a valve running through there. So if you ever see what looks like a valve in an artery, probably a dissection, okay? Put color on it, if it's red and blue, guess what? You're right, it's a dissection. And that's what it says. You have two different types of dissection. Just read over them. They're really simple to understand. The proximal dissection doesn't extend into the ICA. But then you have a distal ICA dissection, which is on page 65. Obviously, it extends into the ICA. That's why it's called a distal ICA dissection. So on a test, I'm going to ask you which dissection extends into the ICA, proximal or distal. Obviously, it's distal. It has it in the word, okay? What is a dissection? It's a tear in the intima that allows blood to flow into the media. And it has to be caused by trauma. The symptoms of having a dissection on page 65. So if you have a dissection, you may have some ischemia. You could have a stroke caused by the ischemia, headache, and obviously neck pain because you've had some sort of trauma there. Alright, we're almost done. I promise. Carotid body tumor is the next thing. It's on the bottom. A carotid body tumor is found, if you'll look on page 66, this is a better way for you to look at what it is. It's found between the ICA and the ECA. Alright? So it causes the E and the I to bifurcate way apart from each other. The bigger the tumor gets, the farther apart they're going to be. It forms in between the E and the I. Carotid body tumor. It's fed by the ECA. Okay? So carotid body tumor, like it says under the ultrasound appearance, it causes splaying of the I and the E, causes them to bifurcate further apart because as the tumor grows. It says it looks like thyroid tissue lying between the E and the I. It's fed by the ECA. You have to add that in there. And it may be highly vascular. Like I was telling Kim on her neck, anytime you find something, if it has blood flow going to it, that means it's getting fed. If it's getting fed, guess what? It's going to continue to grow. So if you find a carotid body tumor, you need to find out how vascular it is. If it's still got a lot going to it, it's going to continue to grow. If not, your body's already cut that connection off, and it's going to shrink down on its own. Alright, so carotid body tumor forms between the E and the I. It's fed by the ECA. Alright, last thing, if a patient does have plaque in their artery, they can either have what's called a stent put in, and a stent, most of y'all probably know what a stent is, it goes in, pushes the plaque against the walls and causes the artery to open. Alright, that's what a stent is. On the top of 67, stents are very easy to find. See the very first ultrasound image? They're bright white walls. See, that's what any kind of stent that a patient has, that's what it's going to look like. So it's pushing the plaque against the wall and opening the vessels. One thing the book doesn't add in here is they can have what's called an endarterectomy. Endarterectomy. I know it's time to go. I'm trying to hurry.
It's on the end glass sheet.
Okay, good. Well, that's one one word I do know how to spell. Endorectomy. An endorectomy is where they actually go in and clean out the plaque. So they can go in and clean out the plaque, suction it out. If that don't work, or if for some reason the patient's not a candidate for that, they can go in and put a stent in, and it'll hold the vessels open. So hopefully I've covered everything on your homework. If not, there it is.
Excuse me, Mrs. Davis. In the endorectomy, does an ultrasound person need to be there during the operation?
Yes.
Okay.
You'll get called into surgery, you'll just keep the probe there, make sure that they clean the artery all the way out before they open them back up.
At the very last one, the intima hyperplasia.
Yeah,
Yeah,
that's what I missed, but I didn't want to keep y'all here any longer.
Why not?
And since you're in here, you're asking, intima hyperplasia is at the top of 67. It's a common problem of having a stent put in or any sort of surgery. Your vessels will reach the nose within 6 to 24 months after having that. It's at the top of 67. See, it says reach the noses by intima hyperplasia. That's what intima hyperplasia is. It's the plaque that you cleaned out forms again. And it usually is within 6 to 24 months after having a stent put in or having an endorectomy. Did I answer everything on that? Thank goodness. Okay. It's so confusing with this really being used for 2 classes. I don't know what to do. Yeah, you keep the in class. That's just for you to use to study.
Instead of writing that stuff like that.
Yeah.
Oh, you're right.
She doesn't do a lot of that.
You are right.